Hello, good afternoon, and welcome everybody to this next and final shared learning event for Alliance 16. Just before we hand over to our guest speaker today, I'm going to hand over to Andy for those all-important messages. Thank you, Andy.
And good afternoon all. Just take the next slide, please, Tim. So just a quick message from me. It's the same throughout all of the events we put on, really. So if we could just ask people if they're speaking to pop their cameras on, really helpful. And when not speaking, if we could just go on mute just to cut down any background noise. With regards to questions, what we'll aim to do is run a short Q&A session at the end. Please do feel free to put any questions in the chat box, as we'll pick those up at the end as well. But we'll take it through to the end, and then we'll do a Q&A session there. That's probably it from me at the moment, so I'm going to hand back to Tim. Thanks, Tim.
Thanks, Andy, and thanks for the opportunity to speak today. Hello, everyone. My name is Tim Gillatt. I'm a Senior Improvement Manager with eSyst, and I'm going to talk to you today a bit about the Safer Patient Flow Bundle, which hopefully you'll be familiar with. This is one of our keynote products in eSyst, and I want to give you a bit of the background of it, talk about why it's important, a bit about what the bundle is itself, and then maybe some tips on implementation, how to do this. But I think one of the key messages really is to keep this as simple as possible. This is really about a set of simple rules which, when delivered consistency, can make a real difference to improving flow through inpatient wards to discharge. So the key message there, keep it simple. And the other message that I'd want to start off with, which is a bit of a health warning really, is this is really an improvement tool. This is not about performance management. This is about an improvement tool to help teams and systems, and particularly ward teams, to improve the way they manage patient flow and they manage the patient journey through a hospital ward, from admission to the ward through to discharge. So performance management can really kill the principles of the Safer Patient Flow Bundle and really do harm to the implementation, because this is about the way that we work. It's about attitude, it's about behaviours, and it's about culture. So please don't try to performance manage the implementation of the bundle. Now, the background, so my colleague Pete Gordon, who some of you will know, brought the bundle together around 8 years ago, and it came from his experiences of working as an ITU, as a senior nurse in ITU, where some of you will be familiar with the ventilator care bundle, which again is a set of simple rules around patients who are on ventilation should be managed, and the key things that should happen to them every day to ensure their safety and their progress through their journey on ventilation. And it's really important to start here that we look at the problem that we're trying to solve and that we're trying to improve. So there's lots of challenges with urgent emergency care, none more so than at the moment. And we fully acknowledge the challenges that people working in clinical services have at the moment, in these times where demand is increasing, where acuity is increasing, and where flow and discharge seem to be more difficult than ever. But it's at these points that we would argue that it's important to go back to those simple rules. So actually, what we're looking at is where the longest waits are in hospital. This is what the Safer Patient Flow Bundle looks like. And patients tend to wait the longest at the inpatient ward and discharge stage. So this is where the bundle will help you. But of course, this isn't about performance particularly. It's about getting people to change behaviours. It's about connecting people with people on an improvement journey. And it's equally important on an improvement journey to connect with our clinicians and our clinical teams with their hearts as well as their minds if we want people to take action. So this isn't about trajectories. This is about connecting with what makes people come to work, what made people come to work in the NHS in caring professions in the first instance, and really starting to connect back with those motives. And one of the principles here in terms of why this is important, the connection that we can make, is through the valuing of patient time. Again, many of you will be familiar with this and familiar with the work of our friend and colleague, Professor Brian Dolan, around patient time. Patient's time is the most important currency in health and social care. And the key question here is, if you had 1,000 days left to live, how many of those would you choose to spend in a hospital? I've never asked that question and come back with anything other than none, because people don't want to be in hospital any longer than they need to be. And the truth is that 48% of people over the age of 85 will die within 1 year of hospital admission. And the majority of patients who become stranded in hospital, who end up having elongated stays in hospital, are in the last 1,000 days of their lives. So while we talk about our time, and we talk about the time of clinical people, and we talk about waiting in hours, we talk about paying people in time, our time, yes, is important. But Brian would contest that the time of the patients who get stuck in hospital isn't just important, it's sacred, because they're the people who have the most to lose and who for whom time is running out. So that's the compelling story for doing more to reduce length of stay and to get patients home to where they want to be as quickly and as safely as possible. So again, this brings us back to that compelling narrative. What can we do on the inpatient wards and through the discharge processes to reduce waste, to reduce the amount of time that people are waiting, and to ensure that they're discharged in a safe and timely manner? And safe is obviously as important as timely. And here we need to be able to explain things simply. As I touched on at the beginning, this is around simple rules. And we want to be able to explain the processes in a way that is simple. And we want the people who are engaged in the processes, the ward teams, to be able to describe the way they work and describe their processes around inpatient flow, managing ward rounds, etc., that we're going to talk about today, in a way that is really simple, but in a way that comes from a place of understanding. Oversimplifying complex systems is the wrong thing to do, but the literature suggests that by going through a phase of really understanding and exploring the complexity of what we're dealing with and really working through that, and then coming to simple rules, we can put some order into what may seem like chaos at times. So the bundle, again, you'll be familiar with the elements of this. I'm about to go through these one by one. The S is for senior review. The A is about patients having a plan with an expected date of discharge and clinical criteria for discharge that may lead to criteria-led discharge, which of course is one of the main elements of the Alliance 16 programme. F being around all wards that routinely have patients from assessment units pulling the first patient before 10 AM. The E is around earlier discharge, a third of patients going before midday, and R being the process of reviewing stranded or long stay patients. So let's take those one by one. So senior review. All patients should have a review by a decision-making clinician and team before midday. So this, of course, comes to ward and board rounds. So the board round, we would suggest, is a process whereby in a book period, the clinical team in its entirety meets to very briefly, perhaps around the board, go through the patients for today, to really start to understand where patients are at and where they go. So they go to the patient bedside or the ward round in a way that they're prepared. So the board round often at this stage will set the key tasks for today. So this is where things like red and green days can sometimes come in. And it's really about setting the agenda for the ward round so people are clear around what needs to happen next. A document that you may be familiar with, but if not, I would certainly commend to you, is the modern ward round guidance that came out from the Royal College of Physicians and the Royal College of Nursing, which ESIS work closely with those organisations on, and we've been delivering a separate collaborative around ward rounds alongside the College of Physicians and the College of Nursing over the last few months. And this sets out some fundamentals around how that ward round should work. And I just want to pick out a couple really of the recommendations that come there. First one I want to pick out is about the roles for multidisciplinary team members and their input to ward rounds. Where possible, we would expect and hope that there would be multidisciplinary attendance on ward rounds from therapists, from nurses, obviously decision-making clinicians, from more junior clinicians in training, perhaps where necessary social care, where necessary pharmacy and others. So it's really important to define the role of those people as part of that process, part of this team process for the ward round. The second thing I'd like to point out here is around reviewing patient in priority order on ward rounds. So there are different models that are available here. The traditional way of managing a ward round is Bay 1, Bed 1 to Bay 5, Bed 6. So it looks sequentially based on where the patient is. In terms of managing flow and optimising early discharge, which we'll come on to in a minute, it's far better to review patients in priority order on ward rounds. So models such as the SHOP model might help here, where we look at the sick first, then potential discharges, then all the other patients, and then prioritising what needs to happen next. So certainly would recommend looking at that rather than going in a sequential way, as that can help really in terms of bringing discharge forward during the day and help with certainly F and the E of the safer patient flow bundle. But I'd certainly commend the modern ward round guidance to you. It's available online. There's a link there at the bottom of the screen, and of course the slides will be shared at the end of the session if people need to look at that. The second one, the A, is often overlooked, but I think is probably one of the more important elements of the bundle, which is around patients having a clear plan that they and their loved ones know about and understand. So this plan should include an expected date of discharge. The word expected is really, really important there. So people use different elements of there. They use words like predicted, they use words like estimated. We prefer the word expected, because expected suggests that there is a plan and that plan is leading to an expected outcome rather than estimated, which it could be argued is a bit looser and in some ways could be considered a fancy guess. So this is all about plans that lead to an outcome that would be expected once the plan is executed. And then the clinical criteria for discharge and the decision around whether the patient is suitable for criteria-led discharge. And it would be really interesting if you've got examples from your work on the Alliance 16, the chat around this. It'd be really interesting to hear around criteria-led discharge and how that's worked alongside plans and the progress that you've made in your teams around criteria-led discharge through the programme. Now, the plans are really, really important. It's the plan in the patient's record. There's some common phrases that we see in medical plans, which we would argue aren't necessarily always that helpful because they're not precise, they're not clear around what we're trying to achieve. So phrases like home when stable, home when mobile. So what does mobile mean? Start discharge planning at home after the weekend. Why particularly after the weekend? Why is Monday a more appropriate discharge date than Saturday, for example? Medically for discharge when back to baseline. So my wife had a laparoscopic cholecystectomy after a period of illness earlier this year. She was discharged through day surgery. Was certainly not back to baseline. She normally runs 10k 3 times a week. There was no way she was going to be running anywhere for at least a month. So she was certainly not back to baseline, but she was going home because that was the most appropriate way for her to continue her recuperation and recovery. And sometimes phrases like recheck bloods tomorrow. If they're okay today, there needs really to be a clinical rationale for rechecking bloods a further day and keeping the patient for a further day if everything is okay today. But things that we often find there. And I just wanted to run through a couple of examples really around what a good clinical criteria for discharge might look like, and just to give some examples of how language is important. So for a GI bleed, for example, it may be described as fit when there's no further evidence of upper GI bleeding. But what does that mean? Let's look a bit more precisely at that. So the criteria for discharge might be no further loose black stool, an HB doesn't drop by more than 10 in 24 hours, asymptomatic postural blood pressure drop of less than 10, an OGD to be arranged as an outpatient if not done by the time that the criteria is met. So there's just a bit more precision there in terms of a clinical criteria for discharge than a more general statement around no evidence of further upper GI bleeding. Another good example of a patient with pneumonia, fit when patient feels well enough. Well, what does that mean? How can we talk about that a bit more clearly? So that patient perhaps will be afebrile for 24 hours, not requiring oxygen for 6 hours, and the neutrophil count less than it was at admission. Again, measurable outcomes there that we can be clear, meet that, deliver a clinical criteria for discharge. But it's important to note that while medical criteria and clinical criteria are important, functional and emotional criteria are really important too, and working with patients and their loved ones is important too. So what does mobility mean? So it might be agreed that we want the patient, or the patient needs to be able to walk up to 10 meters prior to discharge. And that's because that's what they need to do when they're at home, if they want to work their way around their home and to perhaps make it to the bathroom and to bed. But what does the patient really want? And it's important to have the risks being explained to them and their family, the risks of discharge and equally the risks of staying in hospital. And these clear plans, clear medical plans, are really important. And here's another live example of, I think this looks like an exacerbation of COPD. So treat with oxygen to maintain the SATs at 88 to 92%, nebulized bronchodilators, oral prednisolone, and for follow-up with the acute respiratory service at home on discharge. That's the plan. And that then leads to the clinical criteria for discharge, which are able to maintain the SATs without oxygen, able to manage the toilet, and able to mobilise 10 yards. And then the EDD, this plan takes it further still. There's an EDD of the 4th of July, but also a time. So they're planning for early discharge here. So there's no reason this patient could not leave the hospital at 11 a.m. on the 4th of July. And that again gives a bit of a target in terms of discharge planning. TTOs, discharge summaries, etc. could be done the day before to ensure that the patient's ready to leave in the morning. And working with patients, as I mentioned, is really, really important. So there are 4 questions that we believe that patients should be able to answer, and these really do fit with a clinical plan. So the 4 patient questions: do I know what's wrong with me or what is being excluded? In medical planning terms, that's a diagnosis. What's going to happen now, later today and tomorrow to get me sorted out? That's the plan. What do I need to achieve to get home? That's the clinical criteria for discharge. And if my recovery is ideal and there's no unnecessary waiting, when should I expect to go home? Is the expected date of discharge. So all the 4 patient questions do is they turn the clinical plan into something that's accessible to patients and their loved ones. And there's lots of examples of how people have used this to engage patients and their families in their care and to drive the process of discharge. And then moving on to the F, this is around flow. You will note, it's really important to say, this is not about discharge. This is about receiving wards, taking a patient from an assessment area before 10 a.m. every morning. I think from our visits and work with Trust at the moment, this is key. In terms of a number of systems that we're working with at the moment that I've visited over the last month or two, there's a great number of patients in ED and on acute medical units waiting for transfer to wards in the morning. If we could just move that forward earlier in the day and wards start the day taking a patient by 10 a.m, that would make an enormous difference to flow. And there's something in this for the ward teams as well. This is around letting the wards choose the patient. So if I'm a nurse in charge on a respiratory ward, if I'm taking a patient by 10 a.m, I have the conversation either face to face or on the phone with the acute medical unit to take the most appropriate patient. So I've got some control. I'm taking a respiratory patient to my ward. The patient is getting a good deal because they're coming into a bed on a respiratory ward. They're less likely to be outlied. And we've got to make sure that site teams and others, monitor that and make sure it happens. But this is something for the nurses in charge really to work through between the wards and the acute medicine team. And this is something where it's really easy. We'll talk measurement in a little while, but it's really important to measure this and make it visual every day. So if you've got 10 medical wards, how many of those today have taken a patient by 10 o'clock? And to develop run charts and SPC charts that show that's happening or isn't happening on a daily basis, so we can see the impact that's having. And places do this. So Dr. Gordon Caldwell, who many will have heard speak, has spoken on this series, and he's done a number of webinars with ESIST. Gordon's been a real innovator in this, and this is a tweet from him from a while ago. He said in his hospital they schedule discharges for 9 a.m. Then the ward nurses pull patients from acute medicine early to start the day, and this makes a real difference to early flow. So this isn't pie in the sky theoretical stuff. This is stuff that is happening in different organisations and different hospitals up and down the country, and there's no reason. Might take a bit of work, but there's no reason why it couldn't work in your organisation. Because, of course, what we often see in terms of in-hospital flow is late transfers. So this is a chart that shows a typical DGH with patients' movements. So the late transfers you see there in the blue, and what we want to do is move to the orange, where transfers from AMU happen earlier in the day. Because what tends to happen is that when this happens so late in the day, there's congestion at the front door. And equally, from a patient perspective, patients are moving. The moves tend to happen between, say, 5, 7, 8 o'clock in the evening, which is a time of drug rounds, protected meal times, all sorts of things get in the way, shift handover to night shifts, which creates a bad deal for the patient, but equally a bad deal for the ward teams who are managing those patients, having to work with these discharges and transfers. The E then is around a third of discharges happening before midday, and it's really important to point out this is a third of the required number of discharges. So we'd really advocate that you know what is your medical take on a typical day, and that will typically be within, if you look at the last 6 weeks, it's Friday today, if your last 6 weeks average is, say, 50 admissions, you mean from those last 6 weeks, you will be not far off if you work on a projection of 50 today, unless there is something unexpected happening. So if you've got 50, that's a bad sum. Let's change it to 45. So if you're wanting a third to go before midday, a third of your required number of discharge will be 15 discharges going by midday. If your medical take is 45. So this isn't a third of the number of that go, it's a third of the number that you need to go to cause an admission. Because this will then affect that mishmash, to take it a bit further, of emergency admissions and discharges. So this is a typical attendance profile and a decision to admit profile. If we layer on top of that the discharges, so this is a typical discharge profile. So discharges going later in the day than the admissions start to arrive. So if you look at, say, 11 o'clock, just to the left of the 12 o'clock little arrow there, that's when you start to get the build up of patients in ED and in acute medicine waiting for beds on inpatient wards. And then when you, as I said earlier, when you look at the 5 o'clock onwards, that's when you start to get the movement, because the number of discharges going tends to overtake the number of admissions coming. And that's where you get that no bed available time around 11 o'clock to lunchtime, because the discharges are going after the next cohort of admissions arrive. But if we change that and bring that profile forward, so if you look there, that's exactly the same, the admissions, as on the previous graph. But what we've done here is overlay this with bringing the discharges forward earlier in the day. So if you bring the discharges forward 2 to 3 hours earlier in the day, your capacity and demand and that in-day bed swing is more in profile, is where you need it to be. So actually discharges earlier in the day mean that the wards can then absorb today's admissions earlier in the day, and you're in a much stronger position. So flow happens earlier, happier patients, happier staff. And again, there's lots of evidence evolved around this, around the importance of this earlier in the day. Here's one now. I won't read it through this, but this study makes a strong case for improving early in the day discharge to deliver better flow and better patient outcomes. And again, you'll get all this in the slide deck. And going back to Gordon Caldwell's work there, again, just a bit of evidence here. This is around discharges by midday. So if you look to the left of the red dotted line, that was where they were in terms of the percentages, going around the 15% mark. A period of improvement work showed a demonstrable increase in that, and getting up towards, again, it would need to look further to the right in terms of statistical process control to see how this was sustained, and to notice and to be able to show a real validated change and improvement. But there was a start there of increases in the rate of discharge by midday, which also then had a bit of an impact on average ward length of stay as well. So this is stuff that is possible, but important to measure as well. And the R is around reviewing long stay patients, and there's been different ways that we can do this, aren't there? So things like criteria to reside link with this, of course, as well, don't they? There's a daily process around how we do that as ward teams, a weekly process with other people from the organisation coming in to review patients with a length of stay of 7, 14, 21 days. And I really like this letter. This was a letter I was shown on a course that a chief operating officer had received from a patient. I'll read this out because the handwriting is not great. Dear Sir or Madam, this is a request for immediate discharge from the hospital as soon as possible. The reason being that I feel the process of discharge is taking far too long, and I wish to leave the hospital as soon as it is possible. If the request is refused, then I will take it upon myself to walk out of the hospital. Now, unfortunately, this picture of it cuts off the top bit, which has got the date on it, but it's also got the patient's and the address. The patient gives his address as something like, Ward 10, bed 6. So in terms of how that patient feels about his admission, kind of feels like he's been held prisoner here, doesn't it? And he gives his actual address as a hospital bed. Absolutely powerful, that, isn't it? In terms of the way that we sometimes don't empower patients and don't engage them in what we're doing, and the importance of knowing these are free people, and we need to do everything we can to get them home as quickly as is possible. And that's where we need to think about home first. So the principle of home first in the National Hospital Discharge Policy is thinking and asking every day, why not home and why not today? And the discharge policy gives us several pathways, as again, you'll be familiar with all of these. But the work of Professor John Bolton, an eminent social work kind of mind, talks about the percentage of patients who should go on these pathways. So pathway 0, which is the simple discharge with no further input from health or social care, in high performing systems that should be around 50%. Pathway 1, which is simple support to recover at home and able to return home with simple support from health and or social care, is the next 45%. Pathway 2, which is rehabilitation in a bedded setting, should be around 4%. And the final pathway, pathway 3, is 1% of people where there's been a life-changing event and home is not an option. You look at long-term care in a bedded facility, that is just 1%. Arguably, you know, from a health perspective, we overprescribe some of these. We minimise the number of patients in pathway 0 and 1, and the number of patients going through pathway 3 is significantly higher than the 4 and 1%. The change to a home first mindset will start to have an impact on this, but we've got to change practice as well to support patients to get home and to move more closely towards these. I wouldn't expect that many places are delivering at these percentages at the moment, but this is aspirational and certainly something to benchmark against and start to think, what can we do in our organisation, in our system, to move more towards these percentages? Because of course, this is around managing risk, isn't it? And whose risk is this to manage? And the Royal College of OT published a couple of years ago now, and it's been updated since, their document Embracing Risk and Enabling Choice, which we would certainly commend to you, because this is around what matters to me. So this is around communication with the patient. What are the risks of staying in hospital and what are the risks of going home? And whose risk is that to manage? So here's a classic example. So consider the grandmother who wanted to go home but was kept in hospital because her cluttered home was perceived as a risk. The decision may seem to have been taken in the best interest of the individual, but is the result of falling into the trap of not fully taking all of the factors into account and setting our own standards really against of what we would expect in a home against what people live with. But consider the outcomes for the lady, for the grandmother. She entered a cycle of hospital-acquired infections and never went home, although her cluttered home was not the cause of her original admission to hospital. I think this is a classic example and something we see and hear about an awful lot. But whose risk is it? Whose risk is that cluttered home? And Dan Thomas here, a doctor, tweeted around this as well. He tries hard not to make assumptions, but was very surprised recently when a woman in her mid-90s told me that the main reason she wanted to go home with a package of care rather than to a care home was for her Sky Sports bundle. Shows the value of getting to know patients' interests. So what matters to you? And that was the key thing that happened to this lady in the mid-90s, the Sky Sports bundle. And that had mattered to me too. Other tools that can help with this and other campaigns that help with this, you'll have heard of the NPJ paralysis campaign, which is a real example of connecting to people's hearts, connecting to what drives and motivates people around helping people helping patients and people to mobilise in hospital to reduce reduce deconditioning. And simply getting dressed empowers patients, makes them feel the part of it rather than pyjamas, which, as Brian says, can be seen as the uniform of the unwell and really make them supplicant to the powerful clinicians and the powerful systems that our hospitals and healthcare systems have. And of course, pyjamas say you're unwell, but clothes say you're getting better. We would all look better fully dressed. If I was delivering this session in my pyjamas, you'd probably think I looked a bit ill, but it's probably not the best image to go with today, so I'll leave it at that. And we need to, as an improvement teams, we really need to know how we're getting on. So for every ward, we would recommend the wards have a know how we're doing boards. They can see the progress that they're making. Are things improving? Are they the same or getting worse? And people don't have time to hunt this information, but they want to know that what they're doing is making a difference because that's what connects with them. So we need to have processes that make it easy to display that information, and informatics teams who can deliver SBC charts on a regular basis of 2 or 3 key simple metrics, and perhaps Pareto charts as the bottom one around what are the constraints. So things like red to green, for example, will identify key constraints. So it might not just be what gets Mrs. Smith home today, and that might be the specialty review, which is highlighted there. But once you add all those constraints together, you then can start to pick at the processes there as well, to review your processes, improve your processes. So the first ones that you go at there would be that specialty review. How do we ensure specialty review happens? Because that's where the biggest constraints are. What about packages of care? Because that's the next one. And as we start to address and improve those and show on the SPC charts the improvements on those, the next ones become the most contributing ones. So diagnostics and equipment will be the next ones to deal with as those graphs change. So really important to use improvement tools, improvement techniques to deliver this. And we talk a lot about perfection being the enemy of better. We can be so obsessed with what we don't do well, or what we want to get perfect, that we forget to see what we do well, and we forget to see what we can do a little better. Perfection is a longer term destination, which we'll probably never get to, but don't let perfection be the enemy of better. And again, it's difficult at these times. I completely know that, and I half hesitate to say this, but whatever you're meant to do, do it now. The conditions are always impossible. But when we think back to the experience of COVID in hospitals and across wider systems, the amount of change and improvement that went off there, and you can connect with some of that through things like the beneficial change programs to really start to understand the changes that people made, with just in days, if not hours, around there. So we'd always recommend that we look at the 2 levels down rule. So if we're thinking what can you achieve in a year, well, what could we achieve in a week? You're thinking what can we achieve in a month? Well, what could we achieve in a day? Thinking what could we achieve in a week? Well, what could we achieve now? What could we change now? And this is about using improvement science and improvement science tools to really start to make a difference, but just take it one step at a time. Because you don't have to see the whole staircase, but it's important to take that first step. The Safer Patient Flow Bundle, I don't think there's anywhere we would say does it perfectly. I think there's places do different elements of it well, and we'd equally say keep persevering at it, keep using improvement techniques to deliver it. And the minute you stop trying to do it is the minute that you stop doing it.